change the interface and I can't find anything. So we are recording this evening. Welcome, everyone. This is a discussion of preventing gun violence sponsored by the League of Women Voters of Colorado. This is the Task Force on Gun Violence Prevention. I'm Rianda Osman. This evening, our guest is Lena Hellman, the Director of the Office of Suicide Prevention. This evening, Dr. Hellman will talk with us about the work of the Office of Suicide Prevention throughout Colorado. We're recording the session and the recording will be posted on the League's YouTube channel. Lena will have time to respond to questions, and I ask that you put all questions in the chat and we'll address them at the end of her remarks. Before we start, I would like to remind us all that the League of Women Voters is a grassroots organization that has worked since 1920 to improve local, state, and federal government and to engage all citizens in the decisions that impact their lives. The Colorado League, our own, was founded in 1928. Now, the League neither supports nor opposes candidates nor parties, but we do interact with elected leaders at all levels based on our positions on public policy, and our positions are formed after member research, study, and consensus. We are passionate advocates, both women and men, who work to influence public policy issues. And now I'm pleased to introduce Lena Hellman. And so, Lena, welcome.
Hey, thank you all so much for having me. I really appreciate it. I will go ahead and share my screen. All right, are you able to see that?
Yes.
Okay, wonderful, great. And I'm going to try to make your, images so I can see them here too. Oh, there we go. All right, great, thank you. So I will be presenting today. Have a lot of information for you, so I'll go through it pretty quickly and then have some time for questions at the end. So first, thank you again for having me. My name is Lena Heilman. I'm the Director of the Office of Suicide Prevention. We are housed at the Colorado Department of Public Health and Environment. And today I'll be talking about firearm suicide prevention here in Colorado. So what I'll be covering in a short amount of time is an overview of our Office of Suicide Prevention, or OSP, looking at some research and national data, especially around suicide. I think it's really important to understand the landscape of suicide and the impact of suicide and suicide prevention before we focus more narrowly on firearm suicide and suicide prevention. We'll do a deeper dive on Colorado data. I'll talk about some OSP programs and priorities, and then really focus on lethal means safety, and then share with you some additional resources or places to go if you want to continue learning about this topic. So first, here is my Office of Suicide Prevention team. We're a great team all here at the Department of Public Health and Environment working to reduce suicide. Our mission is that we serve as the lead entity for suicide prevention, intervention supports, and post-prevention efforts here in Colorado, which we do by collaborating with our community statewide to reduce the impact of suicide. I also want to give a brief shout out to my colleague here on this slide, Kaylee Kessel, who helped me with a pretty compressed timeline to put our slides on the newest CDPHE template and make them accessible for you all. That was a big lift. So thank you, Kaylee, for helping out behind the scenes with this presentation. I really appreciate it. So whenever I talk about suicide and suicide prevention, there are some key messages that I really hope that you walk away from a presentation with. The first is about the preventability of suicide. We know that there is so much we can and should be doing to make suicide as preventable as possible. And I'll be talking about those approaches throughout this presentation. The second is that suicide and suicide prevention are community issues. There is no one sector or group or place or community that alone can reduce or prevent suicide. We all need to be working together at the national, state, and local levels across all sectors to make suicide as preventable as possible. Third, prevention intervention and postvention efforts are all important. If you're not familiar with those terms, that's okay. I'll be talking about them a little bit more. But we really want to be talking about a continuum of suicide prevention that includes prevention, intervention, and postvention. So hopefully those terms will become more familiar to you throughout this presentation. And the fourth is about sharing stories of hope and resilience. So often, suicide prevention has focused on stories of really traumatic and tragic death, and those are really important. But we also know that the majority of people who experience suicidal despair go on to survive their suicidal despair. And it's really important for us to hear those stories so that we are sharing messages of hope and resilience. So this is a little bit of a busy slide, and I'm not going to go into it in a whole lot of detail. But if you're interested in some of the theories around suicide and suicide prevention, I would encourage you to look at Thomas Joiner's model of suicide. There's a book that he wrote called Why People Die by Suicide that really looks at this model. And I'll be talking about this just a little bit later on too, because there's a piece of it about the lethality of a suicide attempt that's really important for our conversation today. But generally speaking, what Dr. Joyner and his lab and team concluded and what they model is that suicide risk contains multiple parts. So if someone is feeling suicidal, and if someone feels like they are a burden, and if someone feels like they no longer belong and they feel really hopeless about this situation, and they have access to lethal means and a capacity to use that lethal means, that combination can contribute to someone making a lethal suicide attempt. So I'll be talking a little bit about how our work plays into this theory. Again, that's just a really quick high-level summary of a really complex theory, but really important, I think, for us to carry with us that feeling like a burden and feeling like someone doesn't belong, those are really big components of suicidal despair that we want to be really thoughtful around. So a lot of our work focuses on helping people feel connected and feel like they are part and included in their community. And we have components of our work that address that acquired capacity and lethal means. And all these pieces fit together for us to make suicide as preventable as possible. So when we talk about suicide and we talk about what might increase the likelihood of someone experiencing thoughts of suicide and what might decrease, we talk about risk and protective factors. So risk factors are characteristics or circumstances or situations that make it more likely that some individuals will consider, attempt, or die by suicide. Protective factors, on the other hand, are characteristics or situations or circumstances that make it less likely that someone will consider, attempt, or die by suicide. So probably it's pretty clear to people that our work is really to reduce the risk factors, to understand what the risk factors are and to reduce them, and to understand what the protective factors are and to increase them. So a lot of what our office does is about finding those risk and protective factors and increasing and decreasing to make someone's situation as safe and inclusive as possible. All right. So our office implements what we call a comprehensive approach to suicide prevention. Our comprehensive approach contains 6 key strategies. The strategies are 1, connectedness. People who feel connected to their communities, their workplaces, their neighborhoods, their schools are less likely to feel suicidal. And if they do feel suicidal, are more likely to have the resources in place to navigate that despair. The second strategy is economic stability and supports. We know that people who have access to safe and affordable housing and food security and transportation are less likely to experience suicidal despair. And if they do experience suicidal despair, are more likely again to have the resources in place to have access to care and to manage that crisis. Our third strategy is education and awareness. This conversation here falls into that category. We're talking about suicide, suicide prevention, and making sure that people have all the appropriate information so that they can go on and share that information with others and have an accurate understanding about what might drive suicide and what the resources are. Our fourth strategy is access to safer suicide care. So, a lot of our work with providers, with health systems, with doctors, with
Okay.
therapists falls into this access to safer suicide care. So, we want people who experience suicidal despair to receive the appropriate treatment or therapy or support for them. It might fall within the traditional medical model, or someone might need a different sort of safer suicide care appropriate to their own situation. Our fifth strategy is lethal means safety. Knowing that the method someone might use to attempt suicide is really important too in thinking about would somebody survive a suicide attempt. And I'll be talking about that, of course, a little bit later here. That's a lot where our firearm suicide prevention work fits, is in this fifth category. And then our sixth category is postvention. So these are the resources and supports that are provided after someone has experienced a suicide loss, either personally or in their community. This also involves safe media reporting and supporting people who've survived their own suicidal despair or attempt, or supporting families and loved ones who support someone experiencing suicidal despair. So everything in the postvention is about people who have been impacted by suicide. All right, so now we're going to take a look at some of the research and national data and look at suicide across the United States first before going to Colorado. Before I move to data, I go through this section pretty quickly. There's a lot of data I want to share, and it's also sometimes really hard to do so because this is really important data because it represents people's lives. So before I go through the data, I wanted to pause here and read this quotation, which says, "Statistics are human beings with the tears wiped away." So all the data that we share represents human lives. This is really important to me. I lost my sister to suicide, which is why I'm in this work. I know that this data represents her, it represents people like her, it represents people like me and my family who've lost loved ones to suicide. I know many of you on this call have probably been personally impacted by suicide. So although I'm going to talk about data and talk at a pretty high level and talk about trends and proportions of fatality, I do so really, truly holding love and compassion in my heart for all the lives that this data represents. All right, so big picture. Each year in the United States, about 13 million adults think seriously about suicide. Almost 4 million adults make a plan to die by suicide. About 1.6 million adults make a suicide attempt. And we have about almost 50,000 people dying by suicide every year in the United States. So in 2022, there were 49,476 deaths by suicide in the United States. That number was slightly higher in 2023. Another way of looking at very similar data is that for every one death by suicide, there are 4 hospitalizations for suicide attempts, 8 emergency department visits related to suicide, 27 self-reported suicide attempts, and 275 individuals who seriously considered suicide and did not die by suicide. This data is really important for us for 2 reasons. One is that if we're only looking at suicide fatality, we are missing the really big picture of the impact of suicide in our communities. So it's really important for us to also understand people who are attempting suicide and not dying by suicide, and people who are experiencing suicidal despair, because if we're just looking at fatalities, we're missing a really big picture of impact in our communities. The second reason this data is really important is because, again, we see from this data that recovery and resilience are really the most common occurrence. the likelihood that someone is experiencing suicidal despair is that they will survive that suicidal despair. So we want to share with other people, you're not alone. Many of us have experienced suicidal despair and have gone on to survive it and found really purposeful, joyful lives. And that's a really, really important, hopeful message that we want to share. So, again, when we're talking about suicide and suicide prevention, we want to focus a lot too on how are people overcoming suicidal despair? What are the strategies that are working? Where is the hope? And how can we build on that? This is a map of the United States, and this shows the suicide death rates per 100,000. This is data from 2022 from the Centers for Disease Control and Prevention. And the darker shaded states show higher suicide rates. And what we see is that the Rocky Mountain region tends to have higher suicide rates than the rest of the country. There are a number of reasons for that. One of those reasons is access to firearms. So you might hear that Colorado has a really high rate of suicide, and across, compared to the rest of the nation, that is true. We also have rates that are in alignment with other Rocky Mountain states. And part of why a lot of the states have those higher rates is because of similar geographic and um, demographics and that access to lethal means. So Colorado is not necessarily an anomaly outside of its region. So that's just an important perspective for us. All right. Also really important when we're talking about suicide and suicide prevention is that it used to be thought that everyone who died by suicide had a contributing mental health condition or diagnosis, that suicide was really the end result of a mental health condition or a mental illness. What we've really seen in our data here in Colorado and what the Centers for Disease Control and Prevention put together in a study in 2018 is that more than half of people who died by suicide did not have a known mental health condition at the time of their death. Really, what we see is a convergence of multiple contributing circumstances that can lead to someone experiencing suicidal despair and potentially making an attempt on their own life. So, what we see are all these factors coming together, and a lot of these factors also have a really high proportion of impacting somebody's thoughts of suicide. So some of these contributing circumstances that the CDC found were relationship problem was really highly indicated, a crisis in the past or upcoming 2 weeks, problematic substance use, a physical health problem, a job or financial problem, a criminal or legal problem, or loss of housing. And there are, of course, many others. So this is really important because our work in public health and in suicide prevention is that we want to work on all, again, of these risk factors or the reasons that are contributing to somebody's experience of suicidal despair. And so if we're only focusing on mental health, we are missing all of these other contributing circumstances. So one thing that we really try to do is work with different agencies, with different sectors, with different community-based organizations to make sure that we are working together across all of these different reasons that people can experience stress in their lives to reduce that stress and to increase access to services or other ways of support so that someone is less likely to experience suicidal despair. All right, I'm going to move over to Colorado data now. So if you haven't taken a look, we have a suicide fatality data dashboard. That's an interactive tool. This is a QR code. You can take a photo of it now. You can also go to the website here. You can also go to coosp.org or Colorado Office of Suicide Prevention.org, coosp.org, and link to it there. This is a snapshot of what that Tableau visualization looks like. So it's a map of Colorado. This here is filtered by counts. So you can see that along the Front Range, our most densely populated area of Colorado, we tend to have the highest counts of suicide death. If you were to go to another tab and look at rates, we see the rates more variable. A lot of our rural and frontier counties tend to have higher rates, although they have smaller counts. We can also see in our data dashboard age breakdowns by sex identity, veteran status, marital status. We can look at method of suicide death. We can look at toxicology reports, injury location, occupation, and so forth. This is really important information for us at the state level to understand the impact of suicide. A lot of our local partners also use this dashboard to understand data for their own communities or counties. So you are welcome to use this data fatality tool to really understand the impact of suicide in your community as well. All right, so looking at suicide fatality across all ages. In 2023, here in Colorado, we lost 1,290 people to suicide. In 2023, and similar to other years, men ages 25 to 44 died by suicide more often than women in other age groups. So on the left is males who die by suicide, and on the right is females or women, and broken out by age categories. So we can see again that men ages 25 to 44 died by suicide most frequently. Here in Colorado, firearms are the leading method of suicide. They're used in about 53% of all suicide fatalities in this combination year period, 2013 to 2023. We can also see a very similar breakdown year by year. Men use firearms more frequently than women do. We know, as I pointed out before, that here in Colorado, frontier and rural communities have the highest rates of suicide. Because counts are lower in rural communities, these trend lines, th- these they're much more variable. So you can see that that frontier line, the blue one, really has these bigger peaks and valleys. And that's partly because when we look at rates compared to counts, the smaller the count, the more variable that rate looks. So we're really looking kind of at a broader window to understand the data. So we see frontier and rural tend to be higher, and then urban and the Colorado average are lower and more close to each other because their counts are closer. This is another way of looking at our age fatality data. We see that almost 70% of suicide fatalities in Colorado are among adults 25 to 64. Older adults make up about 18% of our suicide deaths. Young adults make up about 8% of our suicide deaths, and youth make up almost 5% of our suicide deaths. So sometimes people are surprised. I know that some people think that young people die by suicide at the highest rates and counts. And really, when we look at our Colorado data, that we see adults dying by suicide at the highest rates and counts. This is really important information for us because we need to make sure that the work we're doing supports people of all ages. People of all ages here on this age range can and do feel suicidal, attempt suicide, and die by suicide. So we need to make sure that our programs and what we're thinking about and the way that we speak to and address suicide prevention really is across the entire lifespan. Here's another way of looking at that data. I'm sharing just a lot of visualizations with you all so you can see how we share out our data, what that looks like. This is, again, looking at age categories along the bottom, and then we see male and female, and male being the blue, having, again, higher rates across the lifespan. Some people ask about youth specifically, so just wanted to share this here. This is our youth suicide death rate. We really define youth in this for our data in terms of youth ages 10 to 18. And we've seen a slight increase in youth suicide over the years, really peaking in 2020 and then kind of on the decrease trend since 2020. So we're really hoping that we can continue to decrease the youth suicide rate. We're hopeful and optimistic that we can continue to do so. All right, I'm going to turn now to the Office of Suicide Prevention, our programs and priorities, so you can understand a little bit better about how the work that we do matches and addresses that data that I just shared. Um, I'll be giving a lot of really high level information because there's a lot I can say in a short amount of time. So if you want to look a little bit more at the work we've done, I can turn you to our 2024 annual legislative report available on our website at coosp.org. So a lot of our information is also there if this goes really quickly and you prefer to read some of what we do. So based on some of that data I shared and our data visualization, we have certain populations of focus. First, we focus on youth ages 0 to 18, young adults 19 to 24, working age adults 25 to 64, and older adults 65 and up. And sometimes people say, Lena, isn't that everyone? Like, yeah, our job here at the Department of Public Health and Environment, Office of Suicide Prevention, is to serve everyone. And we know that everyone along the age continuum can experience suicidal despair, make a suicide attempt, and die by suicide. So we need to be sure that we don't lose sight of different age categories and ranges and make sure that our programs are appropriate for all people. We also have a number of communities that we know experience additional disparities regarding suicide, whether that's suicidal despair, suicide attempts, or suicide fatalities that we want to address. And these populations of focus include our veterans, LGBTQIA2S plus communities, Black, Indigenous, and Coloradans of color, people in high-risk industries, and here in Colorado, that includes oil and gas, construction, and our rural and frontier communities. We are also very aware that a lot of these populations of focus intersect. So we spend a lot of time at our office making sure that we also have programs and efforts in place for, let's say, an LGBTQ plus veteran living in a rural community who is in that working age adult category. So we're really thoughtful around understanding that many of us carry with us multiple identities, and we want to make sure that our suicide prevention approaches really are able to serve everyone here in Colorado and meet different needs. And so that leads us to how we think about equity. So our equity work in suicide prevention is about meeting different need. So we understand equity as people have different needs and experience different disparities regarding those risk and protective factors. So we need at our Office of Suicide Prevention to really be thoughtful around what is impacting different communities and individuals and how can we layer on our different approaches or modify our approaches or increase our approaches to make sure that we're reaching the right people at the right time. So equity means understanding people's different needs and working to meet those needs. We also know that discrimination in its many forms can increase isolation, and isolation is a risk factor for a suicide. So the way that I talked about connectedness, feeling connected is protective. So we're trying to increase connectedness while trying to decrease isolation because a lot of isolation can increase suicidal despair. So we know that addressing disparities is also part of our suicide prevention work. So in terms of our suicide prevention strategies, we have a lot of them. These are just some of the bigger categories of the work that we do, but just to kind of give an overview, these layer on again with that comprehensive approach, but just so you're starting to become really familiar with how all of our work really builds on itself is our strategies include connectedness, increasing economic stability and supports, sharing out positive messaging about suicide and suicide prevention, reducing discrimination, which some people talk about also in terms of stigma. We talk about increasing access to appropriate suicide-specific care. We talk about temporary means safety, and again, that's really relevant to this conversation today. Same with collaborative safety planning, follow-up and caring contacts, and postvention support after a suicide loss. This map is in the OSP legislative report if you want to look at it in more detail. Essentially, what we have here is a map of Colorado and all of our counties and some of our higher profile programs to show where they're situated across the state. You'll see that every county in Colorado has at least one of our programs being implemented, and many counties have many of our programs. So our hope is always to increase more work across the state to make sure that we're meeting all the need that we can. This is a very busy slide. I'm not going to read through it all because I know we want to spend some time on lethal means safety too. But this is an overview of the different types of work that we do at our Office of Suicide Prevention. We have some policies that tell us what to do and how to do it, including a school training grant. We have a Suicide Prevention Commission that works as an advisory body to our office, and we work to implement zero suicide, which is that increased access to safer suicide care. We have 5 federal grants that we use to provide funding to our communities across Colorado in alignment with that comprehensive approach. We run a program called the Colorado National Collaborative that I'll talk about very briefly here in a moment. We provide many grants to coroners regarding postvention and reporting on suicide deaths. We have programs like the Follow Up Project and the Gunshot Project. We provide funding and paid media to Man Therapy. We provide public information and education. Again, this presentation kind of falls in that category. And we have a number of public commission work groups. So members of the public are able to join with us, with our suicide prevention commissioners, to come together to talk about the impact of suicide across a variety of topics and work together to identify recommendations to address those gaps or challenges. We have work groups focused on youth, older adults, service members, veterans and their families, rural communities. We just sunsetted the postvention work group, and we have a new work group, the Maternal Mortality Task Force. So a lot of stuff happening with that really great team that I showed the photos of earlier on. So a quick look at our Colorado National Collaborative. We affectionately call this work the CNC. So if you ever hear about the CNC, it's the Colorado National Collaborative. This is a partnership between Colorado and other national partners to look at what happens if we implement to scale that comprehensive approach, those 6 strategies and all the different activities underneath them within certain counties. Will we see a reduction in suicide rates over time? So that's kind of the hypothesis that we've been working on under the CNC. So right now we are funding 15 Colorado counties to be implementing the CNC. So these counties have active suicide prevention coalitions and work groups, are doing suicide prevention trainings, are doing education and awareness, connectedness activities, working to increase and align economic stability and supports. They're working on lethal means safety. They're aligning with our state programs. They're working under best practices in alignment with national guidance. They are aligning with health systems, safer suicide care, and working on postvention responses and postvention plans across various sectors, and to reach all those priority populations or populations of focus that I showed earlier on. Starting March 1st, we're also doing some initial CNC work on the Eastern Plains that we're really excited about, because you can see right now that's a gap that will start doing more CNC specific work on the Eastern Plains starting next week, which is really exciting. All right, so in terms of some of those strategies, because I know that can be a little bit high level and jargony, I wanted to share just a little bit what that looks like so you can have a little bit more awareness how all these pieces fit together. So that third strategy was education and awareness. So here we fund and support a lot of what we call community helper trainings. They previously were referred to as gatekeeper training, so you might have heard both. Community helper trainings are for anyone in the community, be for you, your neighbors, your family, anyone who's a non-provider, to understand what are the warning signs that someone might be experiencing suicidal despair and how to connect someone to services and supports. Community helper trainings are most appropriate for adolescents and adults, and they can range from 90 minutes to multiple days. Some of these community helper trainings include question, persuade, refer, living work start, safe talk, and assist, mental health first aid or youth mental health first aid or teen mental health first aid, soul shop, and then something that's very community helper adjacent, which is Comet, changing our mental and emotional trajectory, which is a little bit more upstream, but can really work well with these other trainings. Right. So I'm going to just do a quick overview of risk and protective factors for suicide. In case these are not familiar to you, I wanted to just make sure that you have some of this in your head as you leave this presentation. So again, when we talk about risk and protective factors, we try to decrease risk factors and increase protective factors. So risk factors can include a mental health condition, substance misuse, serious or chronic health conditions or pain, feeling hopeless, histories of trauma or abuse, a prior suicide attempt, or a family history of a suicide or suicide attempt. None of these are predictive of suicide. We just know that these risk factors can potentially increase the likelihood that someone could experience suicidal despair over their lifetime. Conversely, we have a number of protective factors. A lot of these are focused on social supports, on connection, on increasing connection to safe spaces, to increasing coping and problem solving strategies, to working on policies and cultures that help encourage help seeking. For young people, we know that connection to a caring adult is really important. And again, economic stability, food security, resilient communities, and equity and belonging are also all key to suicide prevention. So, inclusion and connectedness are really important for us. We need to address social isolation and increase access to social support. Connectedness is a key protective factor, and inclusion works to build connectedness. So, one of our key guiding missions here at the Office of Suicide Prevention is that we can prevent suicide by increasing connection. So, I hope that that's something you'll also be able to take away from this presentation today. All right. So, with all that context about suicide and suicide prevention, I wanted to turn to that fifth strategy around lethal means safety. So, first, looking at the landscape of firearm deaths in Colorado. So this is data from 2023. For every one accidental firearm death, there were 52 firearm homicides and 143 firearm suicides. So we're talking about deaths by suicide. The majority of deaths by suicide here in Colorado are suicide deaths. Did I say that right? Majority of firearm deaths in Colorado are suicide deaths. So it's really important for us in suicide prevention to be talking about access to lethal means, especially firearms. And it's important for us to work with other people who are working to reduce gun violence to understand suicide prevention, because we need to be working together to reduce the impact of firearm suicide here in Colorado. So this slide, I'm dropping it in here again, because a lot of what I shared the last 30 plus minutes was around what can make someone feel like a burden and what can make someone feel like they don't belong, what increases hopelessness and isolation, what are those risk and protective factors. That's really important. It is also really important to understand if someone is experiencing a high level of suicidal despair, what are the means that that person might use to make a suicide attempt. So our office needs to be thinking about all of those pieces to make suicide as preventable as possible. So we look at the research and we see that when it comes to suicide and suicide attempts and suicide fatalities, that the timing and the means or the method matter. They matter a lot. So again, we know that in the United States, there's an estimated 25 to 27 suicide attempts for every one death by suicide. So the question, of course, is why do some people survive a suicide attempt and other people don't? And a really big reason is the method someone is using to attempt suicide. So we know that some methods are more lethal than others. Firearms are generally the most lethal method of a suicide attempt. So we really need to be thinking about that intersection. We know that of those people who survive a suicide attempt, over 90% don't go on to die by suicide. So we want, if somebody does get to the stage of such intense suicidal despair that they make an attempt to die by suicide, we want that attempt to be as non-lethal as possible, because the greatest likelihood then, if that person survives a suicide attempt, is that they will not go on to die by suicide. So again, another really key message for us. We also know that a lot of people can carry suicidal despair and suicidal ambivalence for a really long time. And many suicide attempts occur with little planning during a short term crisis. So that going from underlying despair to an increased suicidal crisis and making the time from decision to die to an attempt, that can be really short and compressed. So it's really important for us to understand that for some people, suicidal despair is a really long time span. And for some people, that final decision to act can be really compressed. So, again, that's really important when we think about what are the means someone might have accessible during a suicidal crisis and how can we help keep someone safe. We also know that when it comes to suicide attempts, the intent isn't all that determines whether someone lives or dies. It's that means. How lethal is it? The means that someone might be using. And we see in our data very clearly that access to firearms is a risk factor for suicide. We also know that firearms used in youth suicide usually belong to a parent. So we want to make sure that adults are really aware of young people having access to firearms in their homes, because that is the most likely way that young people have access to firearms. Our final kind of like guiding piece that informs how we do this work is that reducing access to lethal means saves lives. The data is very clear on that. So that is why that is our fifth category that receives a lot of our attention, is because timing and means matter. And here in Colorado, firearms are the leading method of suicide fatalities. So what do we do with this information that's really hard and important? So, our Office of Suicide Prevention priority, the way that we prioritize our work and think about that fifth category, is we ask ourselves in our communities, how can we keep ourselves safe during a period of crisis? We know that that high level of suicidal crisis is time bound. For some people, it might be 30 minutes, for some people, a number of hours. It's not usually a high period of crisis for longer than 2 or 3 days. Even that's a pretty long period of high crisis. We know that if someone survives that high intensity suicidal crisis period and is able to access the appropriate supports, again, the greatest likelihood by far is that someone is going to survive their suicidal despair long term. So we want someone to stay safe in that period of acute suicidal crisis. What we find, what the research shows, is that emphasizing, supporting, increasing voluntary strategies is a really good short term and long term measure to keep ourselves safe. So it's really important, if I'm experiencing suicidal despair, that I know some strategies right away how to keep myself safe. So a lot of what our office does is talk about how do we encourage people and families to know options, to know what is going to work best for me and my family to keep myself safe during that suicidal crisis. One of our key strategies in suicide prevention is that we want to expand options. For a lot of people, when we look at those contributing circumstances, suicidal despair and moving from despair to a decision to die by suicide is marked by feeling like we're losing options, like we're losing hope. There's no way out. I can't get out of this mounting debt or an interpersonal situation or job loss or whatever it is that feels hopeless. It's a decreasing of options that can really contribute to someone going from suicidal despair to making a suicide attempt. So the more that we can do to increase options, we can call 988, we can call a friend, we can keep ourselves safe, we can give our firearm to a friend, we can give our medication away, we can go for a walk, we can sing a song, whatever it is, the more options we have, the more likely it is that someone will feel empowered to overcome and to know how to overcome their suicidal despair. So again, we really focus on those voluntary means to help people understand how can I keep myself safe, because we want to build that resource, we want to build that resilience, we want to build options. We also know that people are key to problem solving. So I know best how to keep myself safe, but I might need to practice and figure out that skill set. So, but if someone tells me, I don't know, like, go to a rock concert, Lena, you're going to feel better. I might not, because that's around a lot of people. I might feel really overwhelmed. That might actually increase my stress. But for me, going for a walk with my dog in the mountains is going to decrease my stress right away. So we really want to be thinking about what works best for an individual. And the same goes with a firearm with access to lethal means. What's going to work best for someone to temporarily restrict access to lethal means during that period of crisis that's going to work best for them? For some people, it might be bringing that firearm to an offsite space. For some people, it might be removing the ammunition, giving it somewhere else. For some people, it might be leaving their home for a number of days and going camping and getting away from that home's environment or situation or access to lethal means. We really want people to be thinking ahead of time about how do I keep myself and my family safe in case I experience a suicidal crisis. So, two trainings that we support and fund that really talk about this are CALM and collaborative safety planning. CALM is a training that's intended a lot for providers. So it's a free online course focus on reducing access to lethal means. And then we have collaborative safety planning. If you ever heard of safety plan, this is a training for providers on how to help someone with a safety plan. But safety planning can really be done also by anyone. So I encourage everyone to have a safety plan. They're good practice. I have one because they also include, like, how do I notice when I'm getting stressed and what can I do for me to help me? So a safety plan is not like someone else tells you what to do. A safety plan is someone works potentially with a provider to say, what is a strategy that's truly going to work for me? Like, what it helps me? Am I really going to call 988, or would I rather text 988? Am I going to call a family member? If so, who? Am I going to call my therapist? Am I going to think about the lethal means that I have accessible? And what am I going to do if I'm noticing my stress increase to keep myself safe? So, a safety plan is really personalized to make sure that it's something that I would do if I were in a suicidal crisis. The plan is brief, it is in the patient or the person or the individual's own words, and it is easy to read. Office also supports a project called the Gun Shop Project, where we work together with gun shops across the state to share suicide prevention resources and materials. And the core message of the Gunshot Project is that temporarily limiting a suicidal individual's access to firearms is a critical aspect of firearm safety. So we work closely with firearm advocates and gun shops across the state and other venues where people sell firearms to make sure that they also have access to suicide prevention resources so that we are cross communicating and making sure that we're sharing that information. Here at CDPHE, again, I mentioned we really need to be focused on that intersection of gun violence and firearm suicide. So also on the call here, I think I haven't been keeping an eye on the participant list, is my colleague Molly Siegel, who's the director of the Office of Gun Violence Prevention. I believe Molly might be coming to speak to you all in the near future as well. And so our offices really work together on that key intersection between gun violence and firearm suicide to make sure that our strategies are working together and that some of the strategies we do, her office doesn't do, and vice versa, but to make sure that across our offices, we are really addressing this issue to its full scope. So if you're interested in learning more about suicide prevention activities and supports, there are a number of national resources. My takeaway for all of you too is if you're experiencing a suicidal crisis or you're concerned about somebody else, you can call 988. A lot of people think 988 is just if I'm the one experiencing suicide, but if it's someone that I'm worried about and I don't know what to do, I don't know what the resources are, what I should say, I can call 988 and ask them to help me problem solve and know what my options are. We have a number of wonderful national partners, including the Suicide Prevention Resource Center, the American Foundation for Suicide Prevention. There's a Trevor Project line, the Trans Lifeline. We work closely with the Zero Suicide program. And then there's two websites here, Live Through This and Now Matters Now, that are based on lived experience and how people can survive their own suicidal despair. Based on stories of other people who have experienced and survived their own suicidal despair. So with that, I will turn it over to Q&A. Want to say thank you again so much for having me here. I'm really grateful. If you have any questions, please don't hesitate to contact me. Here is my email address. I can also drop it in the chat, or maybe one of my colleagues who's here can drop it in the chat. I'm going to stop screen sharing so I can better see you all and spend some time answering your questions. Thank you so much.
Thank you, Lena. Let's see, I see a couple of things in the chat right now. Please continue to add anything that you'd like. Nicole Lamarche says that that's so good to know about 988 because it can also function as a help nurse. And then Michael Viktorov, however, says, I've heard some stories about people calling 988 and being left on your call is very important to us for ridiculous times. I guess there are bumps to be worked out.
The Office of Suicide Prevention, we don't run the 988 line. I know that the BHA, our partner state agency, works with the crisis line there. So I don't have a lot of great information on that, but that's something I can connect with them and follow up with you all if that's helpful.
Okay. And then there's a question from Peter Gerfine. Are there post-vention programs that work with families that have lost a loved one to firearm suicide? If so, where would one look for information on such programs?
Yeah, that's a really good question. I can't think off the top of my head of any program that is specific to firearm suicide. There are a number of postvention programs that I know of that are about suicide loss. Because the majority of suicide deaths are by firearm, I imagine that in any group setting, there'd be a lot of survivors of firearm suicide. But that's another question that I can look into a little bit more to make sure that I'm not missing any resources. In terms of postvention programs, one of the organizations that is doing some great postvention work here in Colorado is the American Foundation for Suicide Prevention Colorado chapter. They have a list of support groups across the state. They also have a program called Healing Conversations, where someone who's lost a loved one to suicide can request a phone call with someone else who's lost a loved one to suicide to connect and share some of that grief. And then there are some events like the Out of the Darkness Walk every fall and International Survivors of Suicide Loss Day in November to help some of those survivors connect. But I'll follow up on that one to make sure I'm not missing any specific firearm suicide postvention programs.
Okay, let's see.
Um,
Alana Smart mentions ERPOs.
yeah,
Extreme,
yeah, extreme risk protection orders, absolutely. So that's one of those strategies that I mentioned. Our office doesn't have a lot of oversight into ERPOs, but we work closely with the Office of Gun Violence Prevention that is doing work on sharing information about ERPOs, how to access them. And so we work together on that. And so I think when Molly comes to present, or I can connect with her for some of that information ahead of time, a lot of the information about ERPOs is on the Office of Gun Violence Prevention website to make sure that we're really coordinating our efforts.
well, what
Yeah.
other what other strategies like ERPO do you recommend? Because I have heard some advice about doing something other than going to court for an ERPO order.
So
What
our Office of
what
Suicide
else do
Prevention, we're
you
really focused on the voluntary first. And so in addition to CALM and collaborative safety planning, we also have a priority for a training called CAMS, the Collaborative Assessment and Management of Suicidality, which is an outpatient suicide intervention. We've trained over almost 3,000 providers in CAMS now, and that's really to help providers, so those therapists mostly, who help someone who's experiencing suicidal despair, to talk about what's driving that suicidal despair, to help keep someone safe during that period of crisis, and ideally to help that person really overcome that suicidal thought. And so we do a lot of effort to make sure that people know what are the resources available to them, and to make sure that all voluntary means are being given, a lot of care and consideration from our office.
Thank you. Stephanie, you have a hand up.
Yeah. Hi, Rhonda. I just wanted to comment your question about, I think it was your question about the non-voluntary aspect of ERPO. And I just wanted to mention that there's a bill making its way through the state legislature now, SB 25034, Senator Kathy Kipp. And that is, that's another tool. If it passes and, through the process and gets signed into law, that'll be another kind of tool in the toolbox whereby a person can voluntarily, if they feel that they represent a danger to themselves or others, and they have access to a fire, or they are thinking about having access to a firearm, they can put themselves voluntarily on a no-buy list, so that gun shops in the state will be unable to sell them a firearm. I just wanted to mention that. We don't know about the final fate of that bill. It's too soon. It's in the Senate Appropriations Committee. Now it'll probably get heard by that committee after the state budget is passed in March. It'll probably have a hearing with that committee in April.
So more tools in the toolbox.
It'll be, if it passes through and gets signed, it'll be just one more tool. Several states have that option. It'll be just one more tool in the toolbox. Like ERPO is a tool in the toolbox, but this one is specifically voluntary, no court proceeding.
Yes, and
Great.
Molly Siegel is here. Molly, would you like to decloak?
I would be happy to. Hi, everybody. Sorry, I'm off camera dealing with kids being out of school, so it's a little chaotic. Thanks for understanding. Yeah, I'm really excited to come present to you all. It was really helpful hearing Lena do all this grounding today, and we work really closely together, as she said. I'm happy to talk about what we're doing with ERPOs, if that's helpful. I mean, certainly with our partnership, we encourage voluntary first and foremost. ERPOS is really one tool in the toolbox and is supposed to be used when other things have been tried first. We are developing a curriculum and we're in the process of finalizing that. We were tasked with focusing on a curriculum for healthcare professionals as newly added filers, but we're also working really closely with the AG's office, who's tasked with a curriculum for educators and law enforcement.
Excellent. Well, we'll hear more about that in April.
Absolutely.
Little plug.
Absolutely. We are just at the hour. I see no more questions. I thank you very much, Lena. This has been really informative. I've put some links in the chat, so everyone should save that if they need them. Let's see. Molly, I'm glad that you dropped by. And thank you, everyone. Have a good evening. Thank
Thank you all so much. I really appreciate it. Have a good evening.
you.
Thank you.
Thank you. Bye-bye.
Okay, and there we all go.